Welcome back to the Doodle Nurse. This is part two of our antibiotics series, where we continue to deep dive into the cell wall inhibitors. In this video, we will focus on mechanism of action, treatment indications, side effects, and nursing considerations. If you haven't watched part one, please pause here and go back to review the antibiotic basics and penicillin foundations before continuing. Quick disclaimer, this presentation is for educational and informational purposes only. Content shared reflects general nursing knowledge and is intended to support learning for nursing students and healthcare professionals. It does not replace clinical judgment, institutional policies, or provider orders, and should not be used as medical advice, diagnosis, or treatment. Please always follow your facility guidelines and please consult an appropriate healthcare professional when making patient care decisions. Antibiotics work by targeting the structures of bacteria that they need to survive. In this section, we're focusing on cell wall inhibitors which weaken the bacterial cell wall, causing the bacteria to rupture and die. These medications are bactericidal, meaning that they kill the bacteria rather than just slowing growth. Cell wall inhibitors disrupt the peptidoglycan synthesis. It is an essential component of the bacterial cell wall. Most bind to penicillin binding proteins, or known as PBPs, preventing the cell wall formation. Because human cells don't have the cell walls, these drugs are generally well tolerated. So, nursing focus most effective in actively dividing bacteria, monitor for allergic reactions, and watch for renal function with many drugs in this group. Cephalosporins are beta-lactam antibiotics. They bind to PBPs, inhibit cell wall synthesis, activate autolysins, and cause bacterial cell lysis. They are bactericidal and closely related to penicillins, but often broader in coverage. As we move from first to fifth generation cephalosporins, remember these three things: increase gram-negative coverage, beta-lactamase resistance, and CSF penetration. For first generation cephalosporins, mechanism of action, the cell wall inhibition via PBPs. Treatments are for skin, soft tissue infections, or surgical prophylaxis. Examples are the cefazolin and cephalexin. Side effects commonly are rashes, GI upset, and very rare anaphylaxis. For nursing considerations, assess any penicillin allergy history, monitor for signs of infection improvement. For second generation, same as all cephalosporins, cell wall inhibition. Treatment is for otitis media, sinusitis, or community acquired pneumonia. Examples are cefuroxime and cefacitin. Nursing consideration, educate patients to complete full course and monitor for GI tolerance. For the third generation cephalosporins, treatments are for meningitis or severe gram-negative infections. Examples are the ceftriaxone and ceftazidime. Side effects are the diarrhea, risk of C. diff. For nursing considerations, ceftriaxone is hepatically eliminated. Monitor stool patterns. For the fourth generation cephalosporins, like the cifepime, it provides broad gram positive and gram-negative coverage. They are commonly used for hospital-acquired infections and serious resistant organisms. Fifth generation is the ceftaroline. This is the only cephalosporin that covers MRSA. It is commonly used for the MRSA skin infections and pneumonia. Most cephalosporins are given IV or IM and are eliminated by the kidneys, so dose adjustments are usually required in renal impairment. The big exception is the ceftriaxone, which is eliminated by the liver and does not require renal dose adjustment. For adverse effects, cephalosporins are generally well tolerated, but nurses should watch for allergic reactions, GI upset, and C. diff infection. Also, some cephalosporins, especially the cefotitan, can cause bleeding due to vitamin K deficiency and a disulfiram-like reaction with alcohol. Cephalosporins are generally well tolerated, but nurses should watch for allergic reactions, GI upset, and C. diff infection. Some cephalosporins, especially the cefotitan, can cause bleeding due to vitamin K deficiency and a disulfiram-like reaction with alcohol. Carbapenems are the most powerful beta-lactam antibiotics. They are given IV only, highly resistant to beta-lactamases, and reserved for severe or resistant infections. The examples are the imipenem, meropenem, doripenem, and ertapenem. Carbapenems cover the gram-positive and gram-negative, and even the anaerobic bacteria. However, they do not cover MRSA, which is an important distinction. Imipenem plus the celestatin. Imipenem is given with celestatin, which prevents renal degradation and increases the drug levels. Important adverse effects include the seizure risk, especially in patients with CNS disorders. Imipenem also decreases valproate levels, increasing the risk of breakthrough seizures. Vancomycin inhibits bacterial cell wall synthesis but does not bind PBPs. It covers the gram-positive bacteria only, including the MRSA. Vancomycin is given IV for systemic infections and oral for C. diff. Vancomycin must be infused slowly over at least 60 minutes. Infusing too fast can cause red man syndrome, which is not a true allergy. Nurses must monitor renal function, watch for ototoxicity, and draw trough levels before the fourth dose. Other cell wall inhibitors, these are the telavancin. It is a vancomycin-related drug used for gram-positive infections, including MRSA, but carries a black box warning for increased mortality in renal impairment. Aztreonam covers the gram-negative aerobes only, and it's safe in penicillin allergic patients. Fosfomycin is a single-dose oral medication used for uncomplicated UTIs. That sums up the part two of our antibiotic series. Once again, this is for educational and informational purposes only. It does not replace medical treatment and clinical judgment. Please follow your policy protocols and guidelines and provider orders. Please like, subscribe, and follow for more. Thank you.